No, I'm not. This is very serious. Very serious. Never make any jokes. Not so fast. You try to- Okay, those are the notes. I promise you. I would like them back. This is a Wolf River. This is a Wolf River, and they're small this year because of the drought. It's not a very good apple, but I thought I'd bring in one to show you. So, good afternoon. I know full well that all of you know how to walk. In fact, we have some very distinguished walkers in this crowd. Trish Ellis is one of them. She walks daily back and forth from Divinity Avenue to the medical school. But I don't know if all of you know how you walk. And toward this end, I present this introduction to human gait. Let me begin with a couple simple parameters and concepts. You can speak of gait in terms of cadence, which is the rhythm or frequency of a stride. Thank you. And in a normal relaxed cadence, we usually take 60 to 70 strides per minute. And a stride is a complete sequence of locomotor movements measured in terms of time or distance. There are distinct stride phases, which you should know about, and they go like this. I'm going to put this up on the board so you don't have to write right now, just watch me. There is a period of time when one foot is on the ground, and that's called the stance phase, support phase, propulsive phase. All three terms are used interchangeably in the literature, and I mix them up too. There's a period of time when a foot is off the ground, and that's called the swing phase. The stance phase can be broken down into distinct subphases. A stride is usually taken as beginning at heel strike. There's heel strike. The next event that occurs is the foot falls flat on the ground, foot flat. The next thing that happens, the heel comes off the ground, heel off, toe off, swing phase. And so it goes, heel strike, flat foot, heel off, toe off, swing phase. Okay, got that? No problem. Now, if you normalize a stride, heel strike thus begins at point 0, and after 8% of time has elapsed, the foot is flat on the ground. After 43% of time has elapsed, the heel rises off the ground and is followed by the toe leaving the ground at 62% of that, and then you are, of course, into swing phase, whereas this is propulsive support or stance. I don't like stance very much, but I use it because stance is just standing there, but it's often called stance phase. So there it is. Heel strike, heel off. Heel strike, flat foot, heel off, toe off, swing phase. Now what I'm going to talk about this afternoon are the determinants of human gait. And there are a number of them. A determinant, in terms of a definition, is nothing more than a movement of an anatomical structure or two anatomical structures with respect to one another. It's just a movement pattern that characterizes us. The functional significance is that these determinants, most of them, tend to minimize the oscillation of our center of gravity as we walk. And as Hugh told you last time, that center of gravity is located within the body, just anterior to the second sacral vertebra, S2. Just a centimeter or two in front of S2, about 55% of your stature measured from the ground. And there it lies. And of course, as he pointed out, it can shift around in the body depending on where your other limbs are. So the functional significance of these is they minimize the oscillations of this center of gravity. Center of gravity nonetheless oscillates, and it oscillates within as you are walking, within a rectangular space that measures about 4.5 centimeters in width and about 5 centimeters in height. And it oscillates, if I make a simple planar representation instead of a three-dimensional representation, like this. When the right foot is on the ground, the oscillation looks like that. And when the left foot is on the ground, the oscillation is like that. And of course, there are periods of overlap when we're walking, but not when we're running, where both feet are on the ground. Now, if I were to pull my CG out from in front of S2 and hold it out in front so you could watch it, and magnify those oscillations as I walk, starting with heel strike, watch this now. This is what it would look like. Okay? It's a corkscrew pattern. All right? And controlling that oscillation of the CG is what the determinants of gait are all about. Determinant 1. It turns out, curiously, that as we walk along, we rotate from side to side about a vertical axis 4 degrees on either side for a total of 8 degrees. This rotation takes place as a medial adduction of the hip on the stance or propulsive phase side, on the stance phase side. Watch me now. Everybody recognizes this would be internal or medial rotation at the hip. Right? I can't do that at the knee. Can't do it at the ankle. There goes my hip. However, if I fix my leg, that's medial rotation. Same thing, right? Just one element is fixed, and the other is fixed. So that rotation is medial rotation on the stance phase side, and what that does is advance the swing phase hip ahead of the stance phase hip. You can see this in people if you look carefully, but you have to be practiced at it. If I walked in front of you like this, see my swing phase getting out ahead of my stance phase? No, I'm a total charlatan. This doesn't exist. The reason why you can't pick it up is it's only 4 degrees. You could pick it up, for example, if my iliac crests were giant, flared, bony protuberances, huh? Then you'd see it. Now, one of the things, and I'm sorry for our guests from MIT, but one of the things that really cranks me off about MIT is every time they discover something, they patent it. All right? I mean, Lee Gehrke's got a zillion patents. Everybody's got patents. They put CVs full of patents. I've got something I'm going to patent. And this is something that will help me show you pelvic rotation. These are pelvic extenders. This, how did I know, Maureen, that you would like this? Why did I think that you would like this? This, and you took a graduate record examination to get into this place? So that's all right, sit down. What you're going to see if I go into swing phase is my swing phase hip get out of here. There are other determinants going on, but just watch the fore aft here. So I'll start heel strike right side. Left side is going to go into swing, 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 right? And of course, I can really, I can turn that one on, and you know, but that's a natural movement. So on the swing phase side, that swing phase hip gets out ahead of the stance phase hip by medial rotation on the stance phase side. Easy money. So what? Okay, let's work through that. This is a very difficult part of the lecture. It's why you really have to have tenure to give this lecture, because you got two belts on and you might let loose of the wrong one. And you'd be standing there with your pants down to here with two red balls out on the sticks. This is not good. I did it once. It was not pretty. Yeah, so you got to be real careful with that. All right. Let's make an assumption that we've got a stilt-like lower extremity with no ankle and no knee, just a hip. Just a hip. And these things are going to move along a right track and a left track. And the right limb comes down here like this. And I'm going to put it in as a dotted line. And it's got an acetabulum sitting here like this. And it's going to go forward in an arcuate trajectory to this point where it has completed its inverted pendular action. So there it is. And what takes over from that point is the left side, which then again goes through an arcuate trajectory to complete its inverted pendular movement. So what we have here is a series of intersecting arcuate trajectories. This makes the assumption that the relative AP position of the hips doesn't change. It remains in the same coronal plane, the same transverse plane here. But in fact, I just told you that's not what humans do. In fact, by medial rotation, on the stance phase side, the stance phase hip lags behind the swing phase hip, which gets out ahead in this arcuate trajectory. And in so doing, the transition point being here, with the pelvis now at an oblique angle, the pelvis lies at this level. The pelvis does not sink down to this point. That point there never makes it. Instead, the transition is made much higher. So, what is the effect of pelvic rotation with respect to the intersection of the arcuate trajectorial or arcuate trajectories? It minimizes or reduces the abrupt inflections that one gets. So your your trajectory now looks like this. Secondly, the effect of pelvic rotation is that for any given angular excursion of the hip, okay, 30 degrees, 45 degrees, 10 degrees, pelvic rotation will increase step length, stride length. Easy. I mean, if you're confronted with something to step over, you know, it's a puddle or chickens have intensively occupied this space that you're about to step over, do you go like this? No. You go like that. The swing phase hip, you throw it out. You're using that distance to increase stride length, right? Pelvic rotation. 4 degrees on either side of a central axis. Number 2. Pelvic tilt. Turns out that the pelvis, during every swing phase, sinks, tips down on the swing phase side by about about 5 degrees. Watch me. I'll come toward you. You can see it better. I'm going to go into swing phase on the left side first. I'm going to do it slowly. Okay? Now just walking very slowly. If I can exaggerate that, right? No problem with that. That's a natural movement used in dancing. If you're walking just straight out, it's a very slight 5 degree. You can't get your eyes poked out in this lecture. All right, you see that? Every time I pick up this leg, down it goes, down it goes, down it goes. So what good is that? First of all, what that represents is a adduction on the stance phase side. Watch me now. If I adduct on this side, the pelvis, I do that. If I abduct, I do that. You'd agree on this side, if I let my limb loose, that this is abduction and that's adduction. Similarly, this is adduction, and that's abduction on this side. All right, so it's about 5 degrees of adduction on the swing phase side, and it occurs right in the middle of the stance phase. And in fact, it occurs, let's transpose this now. We had something looking like this. But its effect is at the zenith of the trajectorial arc. Its effect is right here as you roll over this inverted pendulum. So in fact, the effect of pelvic tilt is to depress the zenith of this arcuate trajectory. So you come down with something a little flatter, like that, depresses here. Now, there are some really, did you have a question? That's a great question. You're always thinking, huh? Just back from a scientific meeting. The answer to Russ Main's question is that it is controlled adduction. And I was just actually about to explain it. But you're dead on the money. Yeah, watch this. It's controlled adduction and the control is provided by the abductors. Key muscles in human gait. The abductors of the hip are the gluteus medius and minimus. Forget the maximus. In normal overground walking, the gluteus maximus is a big, flabby, soft nothing. You know, you can go wander to corridors doing this and you have no muscle tension whatsoever. Right? It's not nice, but it looks bad. But as soon as you start to go upstairs, that thing will turn on, gluteus max. It's a powerful extensor of the hip. In stair climbing, in running, in powerful extension movements, max will turn on, but not in smooth overground walking. The gluteus medius and minimus always turns on, and these are key. These muscles, as you know, come from the lateral aspect of the ilium and insert on the greater trochanter. You know, the stuff that goes down there. We call these the abductors. They are. They abduct. There's my, you know, that's. But nobody really goes around, unless you're in the Nutcracker this season, doing this. It's not attractive. It's not very useful. However, you can believe that the muscles that do this can control you from doing this. The abductors can control adduction. And so on the stance phase, on this side, foot down, my body starts to sink. CG's in the middle. Gravity's pulling on it. They control the amount that that goes down. I mean, you can put a lot into it. You can let them go, or you can attempt not and keep your pelvis absolutely steady. And it's all adductor, all gluteus medius, minimus, abductor function. People who, for whatever reason, have a weakness of these muscles show a very distinctive gait, and it looks like this. The weakness is on the right side in that case. They have insufficient gluteus medius and minimus function. They know that as soon as they lift this limb, they can't control pelvic descent. And they lift this limb, and over they go. So these people are not spastic. What they are doing is lurching. It's called the Trendelenburg gait or lurch, to throw the center of gravity over this limb, which is compromised in terms of the abductors, and then they can pick up the swing of his limb. All right? So the Trendelenburg test, clinical test, is to ask your patient, stand both feet and lift one limb. Ask me to lift my left limb, I can do it. I can adduct, I can abduct, I can raise my pelvis, I can just sit there, and they're all controlling it, and they're really tense. It's getting hot in my pocket right now because they are working, okay? A failure of the Trendelenburg test looks like this. Lift your left leg, please, and over you go. Can't stand up. Pelvic tilt. Number 3, knee flexion during the support phase. It's actually an extension, flexion, extension sequence. At heel strike, your leg is extended, your knee is extended. It's not locked into a fully locked, close packed position, I mean, all the way back, no, but it's extended. What happens is that as soon as you hit heel strike, the knee begins to flex. There's the flexion. And just before heel off, the knee begins to extend again. So it goes extension, flexion, extension, extension, flexion, extension. About 15 degrees. So what? Well, again, if we return to our, let's make it this theoretical stilt-like limb, that doesn't have a knee, and forgetting determinants 1 and 2 for the moment, the trajectory is going to be a high arcuate one, like that. But if you put a knee joint in here, and allow that knee joint to flex, and then again extend, what you would find is that you have shortened the effective length of that strut, and so you have depressed the zenith of the arcuate trajectory. So in fact, knee flexion during support complements pelvic tilt. Both depress the zenith. Yes? It is not, it's not active. You allow the gravity to do this by a careful control of antagonistic muscles across the knee. And the very last page of your handout, and that'll be near the conclusion of the lecture when I give that over to you, you will notice that the quadriceps and the hamstrings have nearly identical electromyographic patterns. In other words, the knee extensors and the knee flexors are firing during the support phase. They're firing because they are providing very delicate control of the knee. So it's basically body weight saying, all right, we'll allow a little flexion, and then we're going to stop it with the quads and go back into extension. But good thought. Yeah, you don't have to actively go like that. It doesn't work that way. So it depresses the arcuate trajectory, and also as you come down on this limb, all of a sudden one leg is going to support 5/6 of body weight. And so this is a shock absorption mechanism. Shock absorption. Yeah, you can imagine how hard it is on you just to go like that and not extend. That's a real jolt. So it's important in shock absorption. Heel strike and heel off have important interactions with the knee. After heel strike, of course, you go into the flat foot position. You achieve that transition by plantar flexion. We all now recognize this, don't we, ladies and gentlemen, as plantar flexion, dorsiflexion. So at heel strike, you go into plantar flexion. This has a very interesting effect. Consider that effect if I didn't allow it to happen, namely that I had a frozen ankle or an ankle in a cast. And I'm sure all of you have observed people in casts and their gait anomaly that results. If I didn't allow that to go into plantar flexion, here's what would happen to me. All right, up I go very rapidly. But, see, here's the length of the radius rod, effectively. You shorten it by plantar flexion, by making more acute that angle between the tibia and the basal foot. That occurs under the force of gravity and is controlled by the dorsiflexors. In other words, if you didn't have a functional perineal nerve and everything out here, tibialis anterior, extensor hallucis longus, extensor digitorum, communis, the perineal muscles, all these things that come down the front of the foot. And you put your foot down and had no dorsiflexors, what would happen is you'd get, and it's a very common phenomenon to observe people with weakened perineal nerve injury, and they'll walk like this. They'll exhibit foot slap and a high excursion, mainly because since they have no dorsiflexors, they don't want to trip. They don't want to toe drag. If they're walking sloppily, it'll go like this. But nobody likes to walk like that because you're just asking for trouble, so they pick up their foot. These dorsiflexors control then this plantar flexion. That occurs by virtue of the body weight driving it, the body weight coming pounding down through the tibia with the fulcrum point here behind the tibia, that is to say the heel. Okay? The opposite thing happens from flat foot to heel off position. Imagine if you went to heel strike, flat foot, and you just kind of kept going. Your excursion would be down rapidly. It's good. In technical terms, that's a face plant. Okay, just remember that. You learned it first here. This would be a face plant going down. But that's not what we do, because we get to a certain point in the stride cycle and we undergo powered plantar flexion. And that is going to be by the plantar flexors, which you all know now are those that comprise the triceps surae, the most powerful ones. There are others. Two heads of the gastrocnemius and the soleus, mediated through the tendon of Achilles. By the way, what table was it that asked me about the derivation of Achilles and the story of Achilles? I had to do some research. I had to go back in a Homeric legend. All right, I have that. I'm not going to stop class time. It's a long story. Oh. The plantar flexors affect this movement. All right, and effectively preventing you from heading down into a face plant, you go off at a less steep angle. So, in summary, 4 and 5. Number 4 is controlled plantar flexion by the dorsiflexors, which, get this now, it depresses the ascending limb of the trajectorial arc. In other words, you're not going up so steeply, you're going up at a more shallow angle. So number 4 depresses the ascending limb of the trajectorial arc, whereas number 5, powered plantar flexion, elevates the descending limb of the trajectorial arc. Richard, this was not satisfactory. You didn't get it, okay? Thank you for looking that way, because if you didn't get it, there's probably just hordes of them out there, but they're not admitting it. The theoretical, forgetting all the rest of the foregoing determinants of gait, the theoretical trajectory is a series of intersecting arcs. And we work on this in various ways. We elevate this part with pelvic rotation. We depress this part with pelvic tilt and knee flexion during support. Number 4 depresses this part of the arc, whereas number 5 elevates this part of the arc. In other words, you don't go up so steeply, nor do you come down so steeply. Let me make this point in another way. this is the theoretical of a stilt limb. But in fact, it turns out that with these first 5 determinants, we have a relatively smooth trajectorial arc. And I can demonstrate that to you if I simply take out my CG, attach it to a piece of chalk, fix it rigidly to my body, and walk along the board. Okay? No secret here. I'm just walking along as I would ordinarily. And of course, you suspect me deeply that I'm back there doing this to make the lecture go better. There is my 5 centimeters right there. And so, as I'm walking, and you have a diagram like this in your handout. There you go, next page. That individual is walking from left to right. I walked from right to left. Who cares? Doesn't matter. I'm going to show you something here now, because it translates either way. Let me put on this trace where the major determinants function. Pelvic rotation elevates the intersection. Pelvic tilt and knee flexion during the support phase number 2 and 3 depress the zenith. Now, watch this. Although I was walking in this direction, your notes, I'm pretty sure, are going in that direction. So that I will indicate that number 4 depresses the ascending limb here. This is number 4. Whereas number 5 elevates the descending limb. Put it simply, Richard, that if I didn't get my heel off the ground and kept it going, it's splat time. But by elevating the heel, I keep myself more on a horizontal plane. Likewise, a fixed heel is going to cause me, as in a cast, to rise up suddenly like this. Right? I mean, I'm going way up, but by going into plantar flexion, as soon as I hit heel strike, I stay steady. If you want to talk about that more in lab, let's do it until you get it. But there it is, the determinants, the first 5 determinants of gait on an actual projection of what my CG oscillates in the sagittal plane. Now, the effects of determinants 1 and 2 are relatively subtle. But the effects of 3, 4, and 5 are not. And if you lose the ability to exercise these determinants, your gait is markedly altered. In effect, this used to happen to people before the advent of sophisticated biomedical instrumentation, prostheses. The only prosthesis that was available for a long time for above-knee amputees, those who had lost both knee and ankle, was a simple peg leg. But the peg leg, robbed, as you are, of determinants 3, 4, and 5, gives you a markedly different gait. I'm going to demonstrate that to you. It takes me a minute to put this thing on. And I like to recall, because this is a literate class, the description, one of the most marvelous descriptions of a peg-legged gait, occurs in a masterpiece of 19th century American fiction by one of our great writers, Herman Melville, who wrote a book, a sea tale, about the search of a demonic whaling captain for a giant albino odontocete whale. And the book, of course, is called Moby Dick, or The Whale. The antagonist, of course, in this book is Ahab, the captain. And Melville does not bring Ahab into the story until nearly a quarter of the book has gone by. But when he does so with words and the creation of an image that you knew Melville had been at sea and he had, in fact, heard and seen peg-legged men. And so here is the account of Melville introducing Ahab, first time he appears in the novel. And so, almost every 24 hours, when the watches of the night were set and the band on deck sentineled the slumbers of the band below, and when, if a rope were to be hauled upon the forecastle, the sailors threw it not rudely down as by day, but with some cautiousness dropped it to its place, for fear of disturbing their slumbering shipmates. When this sort of steady quietude would begin to prevail, the silent steersman would watch the cabin scuttle. And ere long, the old man would emerge gripping at the iron banister to help his crippled way. Some considering touch of humanity was in him, for at times like these he usually abstained from patrolling the quarterdeck, for to his wearied mates within 6 inches of his ivory heel, such would have been the reverberating crack and din of that bony step that their dreams would have been on the crunching teeth of sharks. Now he goes on and gives further description to Ahab, which includes lurching. But what I have done to myself and what was done to Ahab is nothing more than fit myself with a stilt, such that I not only have lost all shock absorption and are banging the decks of a Pequod, but I also have become a stiff inverted pendulum. That would be the beginning of a step, and I go right up and over and down. Another step, right up and over and down. So that is the essential and key importance of having a knee that flexes and an ankle that you can undertake controlled plantar flexion and powered plantar flexion. Okay? The story, don't study for the midterm. Read Moby Dick. There's zoology in it, there's anatomy. It's one of the greatest tales of all time. And of course, Stubbs, the first mate, comes up. The sequence to this, I spend the rest of the afternoon reading to it, and suggests to Ahab that a stub of tallow might be put there, and that just raises all hell. All right. The preceding 5 determinants influence the vertical oscillations of the center of gravity. What about the lateral oscillation? The lateral oscillation is controlled by a unique human feature. And that fact, that uniqueness, is the fact that our legs are adducted, adducted. In fact, if with your X-ray vision you imagine, if I'm standing here, here's the center of my hip joint, and yeah, there it is, there's my knee. My knees lie within my acetabula. As a zoologist, and there are others here, will tell you that this is very, very unusual. It is unique, practically, among Animalia. Our closest relatives, the great apes, do not have this highly adducted position. Some of them, you know, can walk bipedally, but they do so only with difficulty. It goes like this. Gibbons, for example. Gibbons, of course, had enormously long limbs, so they tend to walk bipedally, holding the limbs so, but they're sagittally aligned, not adducted, or slightly abducted. And so when a gibbon walks, you get no, that's what they're doing. It's true. Or chimpanzee, they'll get a big bunch of bananas. They're going to make off with it. It's great. And they get up and they're looking around, but they're going to do the same thing. They engender a Trendelenburg lurch because they know with a limb position here, to lift this limb, they got to get over like that. But we don't do that. Because our knees are medial to our hips, the amount of lateral translation is very small. Look, if I simply lift one limb off the ground, you'll see approximately what it is, what I have to shift. And that happens shifting to the ipsilateral side of the stance phase. Ipsilateral means the same side as the stance phase. So you shift to this side, this side, but you manage thereby, because of knee position, to keep it within a total transverse distance of 4.5 centimeters. If my legs went just straight down below my hips, I would have to move half the transacetabular distance, and that would give me quite a sway to do this. And looking at something's wrong with me, right? But because your knees are so close, the effect is to minimize lateral oscillations. Keep them to an absolute minimum. The next determinant has actually little to do with minimizing oscillations of the CG, but I include it because it's an instance of a very subtle, very small movement that takes place at a joint which is somewhat difficult to understand, the subtalar joint, but which, when you remove it from a person, take it away, causes great difficulties. In order to understand this, I need to show you the pressure distribution across the plantar surface of the foot during the stance phase. You're all so affluent. You all have very nice shoes. Who's got worn shoes? Do you have worn shoes? Yes. They're all new shoes. Your parents must have bought you everything at the beginning of the term. That's a perfectly good. Oh, there you go. Oh, Anthony, I love you. A mathematician. They're always got worn shoes. I should have known this. Can I have one of your shoes? Yeah, anyone. Thank you very much. Yeah, no, this is incredible. Yaley down at the heels. Oh, yeah. Look at this. We'll take up a collection at the end of the lecture. Anthony's shoe shows a normal wear pattern for a human being. Isn't that nice? What you see here is an area of very heavy wear right here at the outer part of the heel. That's his heel strike. When he heel strikes, as I'll show you in a minute, he's going to somewhat invert. All right? He's going to somewhat invert. This is more heavily worn here, as you can see, than it is on the insole side. So after heel strike, flat foot, the pressure is distributed down the lateral surface of the foot And here's flat foot when, of course, the pressure is transferred across the foot from outside to inside. You see this is this shoe, toward the big toe side. And then the last heavy area of wear right here is under his big toe. He starts here. Distribution of pressure goes laterally away from this longitudinal arch, across the ball of the foot, and then off of the big toe. Heel strike, flat foot, heel off, toe off. Okay? You know, he wears these shoes to the exam. He's got it knocked. He's got the answer right there. He's got it. All right, but that is a preface. Thank you, sir. I'll give you a shoe back at the end of exam. I couldn't resist that. That subtalar joint is a horror show. It's hard to understand. You know, the axis of it. It looks like a complicated joint, and ladies and gentlemen, it is a complicated joint. You really have to like subtalar joints to work on it, which I did once. So why I'm so crazy. The joint axis of that joint looks like this. It's oblique to everything, all right? No, it's not transverse. No, it's not longitudinal. It comes out the heel, the calcaneus, and the neck of the talus. It's like that. Okay? Now, normally, that axis lies within about 16 degrees here of the longitudinal axis of the foot. Okay? That would be a normal subtalar joint axis, equal to or less than 16 degrees. What happens then during stance phase of a step cycling is that joint, the subtalar joint, accommodates very slight inversion, eversion movements and some rotary movements of the leg about the foot, which is basically fixed. So as you first heel strike, you tend to throw yourself into inversion. This is inversion, this is eversion. You go in inversion. As you go down into flat foot, you start to evert. As heel off occurs, you're everting, and then you snap back into inversion at the very end, at toe off. But look at here. It's only about a degree of movement. Here's inversion, eversion, inversion. Fine. That's what all of us normally do. However, in individuals, through joint or ligamentous configuration, have a larger angle to the subtalar joint axis. That is to say, it starts to turn this way, get more transverse. That has been called a pronated foot. It would be greater than 16 degrees. And what happens with those people is that as soon as they make heel strike, because that axis tends to be more transverse, the entire foot, watch this now, goes into eversion, right? And they're walking not on the lateral margin of the foot, but on the insole, on the instep. And they are walking on a pronated foot. This is you're marching your way toward a flat foot. And so you tend to stay in eversion throughout the stance phase. A really flat foot is one in which the axis is almost essentially transverse. And what happens there is the longitudinal arch just gives way, and you go immediately into eversion, and by gosh, you're walking on your longitudinal arch, wherein runs the muscles, the nerves, the arteries. It's painful, it's tiring. And you can go into as much as nearly 8 degrees of inversion. And this is a case where the angle is substantially greater than 16 degrees. This inversion, eversion, inversion sequence of the subtalar joint is important because it does take some shock absorption. It does serve that. And also because it is thought to accommodate very slight rotary movements of the tibia as you pass around a fixed foot. From heel strike to flat foot, the tibia rotates approximately medially. Not approximately medially, approximately 10 degrees. And then from flat foot to toe off, the tibia counter-rotates the other way 20 degrees or 10 degrees beyond where it first began. Very slight movements. Now, we know these movements are important through the adverse effects of subtalar arthrodesis. For reasons of intractable pain, that joint becomes too difficult to manage. It has been the practice, and still is, that you simply fuse the joint surgically. You know, you're not going to have movements there. Bone's not going to grind against other bone. You'll be relieved of pain. Great, terrific. However, what you don't have then is a substitute for those slight rotational movements. Those torques are then translated proximally, and they're translated to the next joint proximally, which is what? The tibio-talar joint, which is a ginglymoid joint. It's a hinge joint, and that is not suited to take these rotary movements. And what happens? That joint gets destroyed. So you fix one thing, break another. Let's have, we may have the slides, please. The last two determinants that I note there are relatively simple. They are simply the fact that one tends to shift the body, the upper trunk, toward the stance phase side, and that shift is small, about 1 to 2 centimeters at T1. But you'd recognize this kind of a walk, right? Like, that's just an exaggeration of that. Likewise, the trunk tends to oscillate back and forth on the pelvis. At the beginning of the stance phase, the trunk is most posteriorly directed. It comes forward like this, and then at the beginning of the stance phase, back on the contralateral foot, it's back again. And so you have a swaying motion of the body, which must be a component of some dance that I can't do. Let me show you 2 slides to introduce you to what I leave you with to contemplate. And we could talk about it on Friday. And then I'll close the lecture with a little historical perspective. These little diagrams I have given you as a handout, and what they simply record is the electromyographic activity of the various muscles with respect to the swing and support phases. For example, here, the gluteus medius and minimus, which I have told you is so important in controlling hip adduction. The gluteus medius and minimus on the stance phase side controls hip adduction, the pelvic tilt or sinking of the pelvis on the swing phase side, and here is that activity pattern. Here's what I mentioned earlier. Look, here's the rectus femoris and vastus, which you know to be, rectus femoris, of course, would be a flexor of the hip, but joins the vasti as extensors of the knee. But here are all the knee flexors, and look at their EMG pattern. They're delicately balancing one another, and when you learn to read the little code here, you can figure out why. The adductors are very interesting. You know, we don't go around, unless you're a big horseback rider. You know, adduction's not real important these days. I mean, nobody does that. Unless you're working on a saddle, nobody grips or holds onto things very much like that. But look, so our adductors are very big anyway. Yeah, adductor longus, brevis, pectineus, and then there's the magnus, which is huge. What are we doing with it? Some muscle groups can be biphasic and can serve different functions depending on the joint position. So here at the beginning of the support phase, heel strike, the adductors are hip extensors and medial rotators, which you know goes into pelvic rotation. Yet in this position, at the end of the stance phase, at toe off, the adductors are again stretched, and in this case, of course, they are HF, they are hip flexors. So the adductors do double service. They're hip extensors in this position, they're hip flexors in that position. Read this over and think about it. Here's our anterior tibial group with tibialis anterior and the two extensors showing a preparatory activity at the end of stance and active all throughout the swing phase. Why? Because you've got to hold your toe up. You toe off, and then you want to pick your toe up. Don't want to drag it. So that, and then they really become active right at the end of swing because they know they're in for big-time work controlling plantar flexion, avoiding foot slap. Because this is an intellectual crowd, a crowd of scholars, and including engineers and mathematicians, people of science. I end this lecture with an account of several people you ought to know about. You very much ought to know about one of the great marvels of the late Renaissance, a man who contributed to volcanology, mathematics, physics, astronomy, iatrogenics, what the heck is that? That's physiology, is what they used to call it, medicine, epidemiology, and who is always known, has been now, as the father of biomechanics. He was born Giovanni Alfonso Borelli in 1608. He became a tutee of a man called Benedetto Castelli. Castelli himself was a disciple of Galileo. And it was Castelli who got Borelli his first job as a public lecturer in mathematics at Messina. Although Borelli's legacy is well known, his own academic career foundered and continued to founder. When the chair of mathematics in 1640 opened up at Pisa, he was considered, and in fact Castelli wrote him 2 letters of recommendation. Can you imagine what a letter of recommendation looked like in the early 1600s? To Galileo, but it didn't work. The post went to Vincenzo Ranieri, who was Galileo's choice. Galileo always wins. And then in 1650, when the greatest of all Italian mathematicians died, a man named Bonaventura Cavalieri, Bologna, the chair there came open. And this time, mathematicians from all over Italy wrote on Borelli's behalf. He was highly regarded, but the selection committee, there were some problems. He was known to be a trifle capricious. Furthermore, there was a worry that he was a follower of the moderns, Copernicus, Galileo. And furthermore, his lectures stunk. They went on for 8 hours until the students stoned him with rotten fruit and vegetables. He never got the post. It went to Gian Domenico Cassini. He eventually returned to Messina, and then to resume his public lectureship in mathematics. And then he did something no academic should ever do. He became involved in politics. The local Republicans were agitating against the Spanish viceroy, the Conservatore del Regno, agitating for statehood. And when the Conservatore's house burned flat to the ground, Borelli was implicated, a price was put on his head, and he was forced to flee to Rome, on the way to which he was robbed of all his earthly possessions by a faithless servant. He entered the monastery of Santo Pantaleo, where he spent the rest of his life teaching elementary mathematics, but leaving at his death in 1679 this book, which is the start of biomechanics. It's the start of the MEMP program. And here it is. Look at it. Johannes, or Giovanni, Alfonsi Borelli, the Neapolitan professor, professores, Matheseos, of mathematics, De Motu Animalium, the movements of animals. The first part, the newest, novissima, newest edition. I only have the second edition, from which numerous errors and corrections, repurgata, have been purged and made. And there is added, yes, sunt, added, there is added post finem at the end, the second part. Look at that, Johannes Bernoulli. That's not Dan. Okay, Dan, that's Bernoulli's laws, equations. This is Johannes, adds mathematical meditations on the movements of muscles. Now look at these diagrams. Borelli was interested in everything. The running of quadrupeds and the flying of birds, the swimming of fishes. He even accounts for the air bladder. And he starts designing things in a way that is reminiscent, we begin to think and see, of free body diagrams. It was Borelli who first worked out the center of gravity of the human body by balancing a very, very stiff cadaver on a set of prisms. And he worked it out and published it in this book. You must not forget Giovanni Alfonso Borelli, the father of modern biomechanics. You know, they started this silly society business here at the medical school, naming these societies after all these old New England Caucasian men. And they asked HST, what do you want to name your society? And I put up a ferocious effort and lobbying for Giovanni Alfonso Borelli. It was not accepted, and we're just HST. I wanted that something awful. Another eccentric that you must know about was born in 1830 in Kingston-on-Thames in England. Edward James Muggeridge, who somehow contrived to change his name to Edward Muybridge. We don't know much about his early life of this peripatetic photographer, but he ended up in Stanford in 1872, where he became acquainted with a man named Leland Stanford. Now, Stanford had a little horse farm called Palo Alto out there, and he's a fairly rich man since he'd been governor of California, and he owned most of the Central Pacific Railroad and was interested in training horses, and he was interested in if he couldn't get photographic analysis of it. Never been done. And it was Edward Muybridge who, by 1877, had produced the first sequential photographs of animals in movement. His work was eventually supported by 1883 by the University of Pennsylvania. So important was it, because no scientist had ever gotten a look at daily activities, much less running or other exertional events of humans. And these pictures are as marvelous today as they were when they first were produced by a battery of cameras triggered by springs and rubber bands, and later by ingenious electrical devices. Here's even a little boy walking along. And you know, children don't have that's the difference between the child and the adult. Children don't have a heel strike. They go right straight to flat foot. But he did everything. To the delight of zoologists, he did common domestic animals, dogs and pigs running along, even raccoons. There's everything you can find. Ostriches trotting and sloths. This is not an exciting series. You can see that, but sloth moving along a branch. There's a Frenchman, too, that ought to be named, Edouard Marey. Marey was a physiologist and got a so-called chronophotograph, multiple exposures of a plate of an individual in a black costume with white tape. And looky here, it was Marey who actually saw for the first time some of the basic determinants of human gait, the arcuate trajectories of the pelvis, the heel strike, flat foot, heel off, toe off sequence. Marey should be remembered. Gait studies since that time have become ever more complex. Here's a study conducted at MIT where they've got the pelvic extenders on the wrong way. Everybody knows they go side to side. But you know, early experiments in this kind of effort. Interrupted light photography is now seems old-fashioned because of the incredible advances in technology and the documentation of normal and abnormal human gait. Nonetheless, as sophisticated as we come in our gait studies, both of humans, I'm working right now with high-speed X-ray movies of flying birds. The kinds of things that I related to you today in terms of the basic determinants of gait have not been broken. They are still true, and I hope that they will help you, at least the presentation this afternoon, understand this when you look at normal gait or variants of normal gait or downright abnormal gait. Our dear prosector today is none other than the great Dr. Samuel Kennedy, who leads you into the foot. It can be a long day unless you're expeditious. Hear me. The foot's got it. Now, Brandis won't like this. I said this to her yesterday, and she just went right after me, just right after me. There's no question about it. I said, you know, to me, the foot it's got a lot of muscles in it, but we don't do anything with them. And of course, I was using the imperial we. I don't do anything. I sit in my shoes. She's a ballet dancer and was all over me for this. She's got very powerful feet. She can write, pick up things. So she really wants, she really wants to see the foot. It's got 4 layers of muscles in it. We can't make, at least I can't. Maybe the anthropologists will. It would be a great dissertation. A good functional story out of the human foot. So proceed expeditiously through it so that you can have a look at some of the joint prosections, particularly of the knee, which I trust will be out. Very good. See you in lab. No applause.